It's sort of surprising to realize that we've been using high-res CT for almost a quarter of a century now. It first came into use in 1989 and gave us a wonderful way to look at the lung parenchyma in a very optimized fashion. The three key features being the ones you see highlighted here in yellow, but using a very high spatial resolution algorithm with very thin slices and a constrained small point of a field of view, rather. In the early days of high-res, we would use this in a sampling method, taking images at perhaps 1 centimeter intervals throughout the lung. Now, with helical CT capabilities, we have modified protocols and that's beyond the scope of this particular talk. But you can do volumetric scans now using high-res technique as well. And we end up with beautiful images, as you see here on the right, a patient with early pulmonary fibrosis, really exquisite depiction of the underlying lung anatomy. And you virtually become a gross or macroscopic pathologist. Whatever the pathologist can recognize macroscopically, you can learn to recognize with good high-res images. The indications are as they have been, primarily to investigate patients who are suspected of having interstitial lung disease, but it's also used to recognize bronchiectasis, even subtle forms of bronchiectasis, and to also investigate patients who are suspected of having small airway disease. As in this individual illustrated on the right, a patient with infectious bronchiolitis. You see these small little nodules here and tree and bud formations. We'll discuss what those mean in just a moment. Scanning protocol is pretty basic. Most patients are scanned in a supine position at full inspiration, which is important so that the lungs are fully expanded and the anatomy is spread out in a very nice way for you to recognize all the normal and abnormal findings. You have the option of doing prone images, especially in patients where you suspect early interstitial lung disease, such as early fibrosis. You may have to put the patient prone to look at the posterior lung zones without the effects of gravity. Similarly, if a patient is suspected of having small airways disease or other causes of air trapping, then expiratory images are a key part of your protocol to recognize that. Most realize that certainly the posterior tracheal wall is a key structure for recognizing whether an image is an inspiration or expiration. And that's based on the appearances you see here. Remember that the tracheal cartilages are C-shaped or D-shaped, and the posterior tracheal wall is smooth muscle. It's membranous. So in inspiration, if you take a deep breath and close your glottis, the pressure will distend the posterior wall of the trachea. It will appear rounded or ovoid, as you see here. Whereas in expiration, the posterior wall will become flattened or perhaps bowed inward within the trachea. And you can see that the lung itself becomes more dense and a little less beautiful on the expiratory image. You have to be careful because if you're looking, suppose that I didn't show you this upper image, I just showed you this lower image, you might be starting to call ground glass opacity here in this patient's both lungs, as you see here. But if you look at the upper image, you realize this was taken in expiration, and therefore this is likely to be artifactual ground glass, and you have to take that into consideration. Now, while we're talking about ground glass, let's just summarize that for those of you who may not be familiar with these terms. It refers to increased opacity in the lung that does not obscure the underlying anatomy. Compare that with a more dense opacity, consolidation, where the increase is to such an extent that you can no longer recognize the underlying anatomy. And here on the right, I actually have a piece of ground glass I just put over some printed words, and you can see, you can still make out the words. So this would be analogous to what we see in ground glass. And I'll show you other examples. So ideally, you'll have a beautiful high-res image like this. This is a normal high-res image. You can notice that the pleural surfaces are very sharply defined along both the costal and mediastinal pleural surfaces. You can recognize that the fissure here on the left is a very sharply defined linear opacity. On the right, remember that the right major fissure is more oblique, so it's not unusual to sometimes have a fissure appear as more of a ground glass type density. If we zoom in, we can look at the so-called broncho-arterial pairs. We know that the pulmonary arteries are paired with and travel with an airway within the lung. And these should be roughly equal in size and sharply defined. And notice the very nice, discrete, thin walls of the airways we do see. Sometimes you'll see a vessel near some branching airways or vice versa. And again, you can make the comparison there by looking above and below these levels. Now, you should not see airways in the outer third or so of the lung. If you do recognize airways in the outer parts of the lung, it's likely that you're looking at bronchiectasis. So let's cover bronchiectasis in these early moments of this talk. In this diagram, you can see portrayed a normal airway that is tapering and branching, and notice it does not extend out into the lung periphery. And then I've had the artist depict three increasing grades of severity of bronchiectasis, cylindrical being mild, varicose being moderate, and cystic being severe. The cylindrical bronchiectasis, if you catch it longitudinally, such as in this individual, especially when you're near the hilum, you might see these airways laid up very nicely. And notice that this does resemble the tram tracks that you see in this illustration. They're parallel walled airways. They are extending out in that outer third, which they should not, and they are no longer tapering. So this is an example of cylindrical bronchiectasis in the longitudinal perspective. Now, what if we looked at this in cross-section and other levels of the lung? Then you will begin to see the so-called ring sign, where the airway is larger than its paired pulmonary artery. And you can see a number of examples here. This has been called the signet ring sign in the literature. A signet ring has a flat surface that is inscribed, so I've chosen to call this a cabochon ring, because a cabochon stone is an uncut stone. I think it more closely resembles what we see here. But be that as it may, this is, I call this the ring sign. You can see there are numerous ring signs in this individual who has cylindrical bronchiectasis, and some that makes you think about more the varicoid degree. It's more moderate bronchiectasis. And notice that these findings are out in the periphery of the lung, which is an abnormal distribution to see airways. The more moderate grade is so-called varicose. You look for alternating areas of constriction and dilatation, as you see here. And sometimes in bronchiectasis of any degree, you might find areas of nodularity, which may represent areas of mucoid impaction. You can sometimes figure that out by looking at prior studies. And the most severe form is a cystic form. These are often in clustered collections, very marked dilatation of the airways, as you see here, quite sort of rounded looking, and sometimes you'll see air fluid levels, and if you do, you should consider the possibility that this patient has an active infection involving the airways. But now let's leave the bronchiectasis behind and start talking about the interstitium, because the interstitial lung disease is certainly the primary indication for performing high-res CT. This is a coronal depiction of the lung that I had an artist prepare to try to show the concept of the interstitium. Now, you and I don't see the interstitium when it's normal. Whether you have the best high-res CT, you still don't see normal interstitium, but it's there anatomically. And there are three components to the interstitial fiber network: axial, peripheral, and alveolar septal. So here's the first one. It's a central sort of array along the bronchovascular structures. And the artist here is showing a pulmonary artery in blue because now it's lacking oxygen, and it's paired with its airways, and these taper and branch together way out to the periphery of the lung. And this is the so-called axial interstitium. You can see this sort of loose connective tissue the artist has drawn. Now we'll jump out to the periphery of the lung for the second component of the interstitial fiber network, the so-called peripheral interstitium. And this is a subpleural loose connective tissue. When I say subpleural, that's along the costal pleural surface, any pleural surface, but also includes the interlobar fissures. And this will be important for you to realize when we look at some of the patterns you're going to encounter in high res. If we look closely, we can see that this peripheral interstitial is contiguous with the outlines here, the septa that form these numerous secondary pulmonary lobules that extend throughout the entire lung. Those interlobular septa themselves are the structure that form the Curdy B lines we're familiar with on chest radiography. Now, for the third component of the interstitium, we've done the axial and the peripheral. Now we're going to zoom into one of these secondary pulmonary lobules. And this here, the artist has depicted the surface of the lung. You can see several of these polyhedral-shaped secondary pulmonary lobules. I've opened one up here to show us this loose sort of packing tissue, if you like, almost like a packing material. And this is representing the alveolar septal interstitium, which is within the secondary pulmonary lobule. Keep in mind that the pulmonary lymphatics basically follow those same pathways. They extend along the peribronchial vascular structures. They are found in the subpleural region, including the interlobar fissures and the interlobular septa. And this will form the basis for the perilymphatic pattern, which we'll cover in just a few moments. And now back to our illustration of the secondary pulmonary lobule. Again, we're at the surface of the lung. We've opened up the lobule. We've removed now all that loose interstitium, and we're looking now at the vessels that supply the secondary pulmonary lobule. You can see the blue pulmonary artery here with its paired airway. This would be a small lobular airway coming into the center of the lobule. And now these are vessels supplying the rich capillary network that then forms the small veins that go into the interlobular septa. Now notice the lymphatics here are depicted in green. So we have lymphatics along these bronchovascular structures here at this very small secondary pulmonary lobular level. The lymphatics then stop at the level of the capillary network, but they reconstitute here on the distal or venous side of it, and you can see that these green lymphatics course with the small veins in the interlobular septa. They also extend along the subpleural region, and keep these lymphatics in mind later when we start talking about the perilymphatic pattern. We want to translate those concepts now into a two-dimensional illustration. This is a very nice illustration from Dr. Webb's book on high-res CT. It's in its 4th edition now. It's sort of the Bible of high-res CT, if you will. And this diagram nicely illustrates two adjacent secondary pulmonary lobules. Notice that here's the pleural surface, the visceral pleural surface. Here are the interlobular septa that marginate, and these carry both veins and lymphatics back to the hilum. And lymphatics also course along the bronchovascular structures. They're not illustrated here, but you can see the airway and the small artery going into the center of the lobule. And the artist also is showing you one of the RSNA that are found within the secondary pulmonary lobules. So the lobular core structures are this small artery and bronchiole, and then interlobular septa, again, carry both veins and lymphatics. So just to reinforce that point now, we're pointing here now to these lymphatic structures, because these will be so important to you when you want to recognize the perilymphatic pattern. Peribronchovascular, interlobular septa, subpleural, and interlobular fissures. So these will all come into play in just a few moments. Now we're going further, digging deeper into the secondary pulmonary lobule. We've taken away the capillary network, opened up some of the little airways here, and you can see the alveolar sacs here being supplied by an airway here that's branching and forming different appearances. And I'm going to ask you a question now. What airway structure is partially alveolated? Now we're down to the small airway level in that illustration. So is it a terminal bronchiole, a respiratory bronchiole? Is it the so-called alveolar ducts, or is it the bronchi? So respiratory bronchioles are partially alveolated. We'll go back to the illustration now, and you can see here that this is a terminal bronchiole coming into the lobule, and it's totally smooth, no alveoli, and it's branching into several respiratory bronchioles, which are both smooth and partially alveolated. And then those lead into the alveolar ducts, which are tubular structures, but they're totally alveolated, and they in turn lead to the alveolar sacs. And here we've opened one up for you to see the smooth, the partially alveolated, the completely alveolated, and the alveolar sacs. And I'll bring in some other labels here just to show you those structures. So if you were a puff of air coming down the trachea into the lungs, going way out to the lung periphery, you'd have a smooth sail all the way to this last conducting airway, the terminal bronchiole, and then you'd hit these partially alveolated respiratory bronchioles. It'd probably be your first encounter with significant turbulence. And it turns out that these respiratory bronchioles are sort of a hotbed of abnormalities in pathology. So keep them in mind when you start to read about some of the pathologic correlate in lung disease, especially small airway disease. There are a number of imaging patterns. They're listed here. So you see reticulation, nodules, increased or decreased density, cystic appearances, and of course abnormal airways. And when you see these imaging patterns, then you want to ask yourself, what is the distribution of these, and how does that relate to the underlying anatomy of the lung? Is it involving the upper, mid, or lower lung zones? Now, when we talk about interstitial lung disease, we tend to speak more in zones rather than lobes. And is it central or peripheral? Is it diffuse or patchy? And keeping in mind the secondary pulmonary lobule, can we see a relationship to those lobules? Is it perhaps central lobular abnormality, perilobular? And can we see relationship to those lymphatics we talked about? So I'm just going to give you an introduction to these concepts. So if you're not familiar with the central lobular concept. Here is one way to enter that. This is an illustration showing a cut surface of the lung. You can see the outlines here of multiple polyhedral-shaped secondary pulmonary lobules. These are the interlobular septa. Remember, they carry veins and lymphatics, and this includes along the pleural, subpleural surface. The yellow circles are showing you the central lobular zones. Within these, and we have a small artery, a small airway, and lymphatics, as I mentioned to you earlier. The artist has also chosen to show a little destruction here. This patient has central lobular emphysema in this depiction, which is another central lobular process. So in high res, we're going to look for the things that occur in the center of the lobule. They're not going to touch the pleural surface. They're going to be some distance from it, 5 to 10 millimeters, and they're not going to be related to these interlobular septa. So here's an illustration I've had done just to show you how you can try to understand these. I think at first glance you might say, well, those look like random nodules to me. How can you call those centrolobular? But now watch as I click. I'm going to bring in the interlobular septa and all this lobular anatomy that underlies this. And we don't normally see these lobular contents, but notice that all these nodules I've depicted are in fact centrolobular. And how can we recognize them? It's easiest to recognize them when they occur out in the lung periphery near a pleural surface. You might recognize that they're evenly spaced. Notice they do not touch the pleural surface. And I'm showing you here an illustration of some that are soft tissue attenuation. Others are a little darker, so a ground glass attenuation. Some are irregular. And I'm showing you some branching centrolobular nodules and some that are both nodular and linear, the so-called tree and bud. And that's a term that confuses people who are new to high-res also. And it just refers to the fact that a tree in springtime has a combination of both nodular and short linear elements that we call tree in bud. And notice how it does resemble these centrolobular nodules that are both nodular and linear here in this patient with a small airway infection. Notice that these are fairly evenly spaced. They do not touch the pleural surface, and these are what we call tree in bud. Now these are, I shot this picture myself one spring morning, and of course these are a wonderful herald of good weather to come, so we'd like to see tree in bud in Boston on our trees, not necessarily in our patients. But in the diagram here, I've drawn a circle to show you what part of the airway structures are involved to form this so-called tree in bud appearance. Compared it now side by side with a larger airway nodule that may occur, the so-called acinar nodule. So this diagram rather is really based on the findings of Dr. M.I.M., a very landmark paper on tuberculosis, where he carefully sectioned some centrolobular tree and bud and showed that the stalk is formed most commonly by the last order bronchus, and the tuft, the rounded part, it refers to as involvement of bronchioles and alveolar ducts. So that's the tree and bud. Sometimes you'll see larger centrolobular nodules, and that they often are so-called acinar nodules. And what I've done here is made the green circle larger, and I've pulled it out more distally. So now it's encompassing an entire pulmonary acinus. Remember that an acinus is everything distal to a terminal bronchiole, which is this structure as well. Now there are multiple acini within a secondary pulmonary lobules, ranging from 8 to up to 24 in some parts of the literature. Here's a nice image of a patient with tuberculosis. This is to show you that you can have all of these findings coexisting in one patient. We have centrolobular nodules and tree and bud opacities here. Here's a tree and bud. Here's probably a small tree and bud. And then we have larger nodules here, which I think qualify as acinar nodules. So they're also centrolobular, but they're larger than our tree and bud opacity. And we have other findings. Let's jump to the most dramatic, the dense consolidation, which totally obscures the underlying anatomy. And adjacent to that, we have a patchy area of ground glass opacity. It's increased density, but we can still see through it. We can still recognize vessels and nodules and other things going on. So this is both consolidation and ground glass opacity. If we look closely, we can see some interlobular septa outlining some parts of the secondary pulmonary lobules, and we can also recognize some airway wall thickening in comparison to a more normal airway in the adjacent parenchyma. So you'll often find these things in combination, and you just have to recognize the findings, the patterns, and then take it from there. So here's our diagram again. Here's some examples. The two top illustrations are little miniature views of two patients with tuberculosis. You can recognize the centrolobular nodules. A couple of them look like tree and bud. This may be a little more acinar in its extent, but notice these also extend into the central part of the parenchyma. They're easier to recognize along the periphery and the subpleural region. Now this image is much easier to evaluate because it's a so-called MIP image, a maximum intensity projection. And these are very useful for detecting any kind of nodules, even in lung cancer screening perhaps, or looking for METs, but it's a very nice way to look at these beautiful tree and bud opacities you can see in a central lobular distribution. The lower right image is a patient with hypersensitivity pneumonitis, and you can recognize these as central lobular, but it's a little harder first to put your mind around this, but these are ground glass opacity. They're a little less distinct to your eye, but notice that they are central lobular. They're fairly evenly spaced. If you look closely, the dark little linear structures are actually the interlobular septa that are not involved by this process. This appearance is most commonly encountered in patients with either respiratory bronchiolitis and a heavy smoker, for instance, or a person with subacute hypersensitivity pneumonitis. And you may be the first person to raise that possibility if you can recognize these ground glass central lobular nodules. On the lower left, it's a patient with Langerhans cell histiocytosis, another smoking-related disease, and their nodules are irregular and often somewhat random looking, but you'll often encounter some that do qualify as central lobular, and often some cavitary thick-walled nodules, and often cysts too. That's a topic that will be covered later. Well, now let's move into perilymphatic distribution. Remember, we talked about the lymphatics extending along the peribronchovascular structures, the subpleural region, including the fissures, and the interlobular septa. And those are all depicted here on the illustration. We're showing you nodules now in perilymphatic, peribronchovascular, subpleural, touching the pleural surface along the fissure, and you can see these also in cross-section when you find the bronchoarterial pairs. This is a patient with sarcoidosis. If you look closely, you can see these very tiny nodules extending along the bronchovascular structures and along interlobular septa, and some are obviously abutting the pleural surface. This patient above has lymphangitic carcinomatosis, and you can recognize some nodules that are also perilymphatic, touching the pleural surface, extending along interlobular septa, and there's also some thickening of the axial interstitial structures here, airway wall thickening, as you see. Silicosis, it's a little more difficult for beginners to recognize the perilymphatic findings there, but they're there if you look closely for the subpleural and interlobular septal involvement in patients with silicosis. They'll often, as you know, have nice small rounded nodules elsewhere. That same perilymphatic distribution can sometimes manifest with a predominant sort of septal appearance, where you'll see the interlobular septa. It may be smooth, as you see in this part of the illustration. It may be smooth and nodular, or it may be seen in combination with ground glass opacity, the so-called crazy paving appearance, which you see in the adjacent case here. The upper left image is a patient with pulmonary edema, a very common cause of smooth perilymphatic gorgement, if you will, and abnormality. The images on the upper right and upper left, these are both lymphangitic carcinomatosis. The upper image, a patient with more smooth involvement, and the lower image, you can see a combination of smooth thickening, but also some nodularity as well. And notice how in both of these, you can very easily outline a number of secondary pulmonary lobules and recognize a central lobular dot in some of these as well. The patient on the lower left has that combination of smooth interlobular septal thickening and an overlying veil of ground glass opacity. We call this crazy paving. Random nodules, as the name implies, are randomly distributed. They do not really relate to the secondary pulmonary lobule. You may see some abutting the pleural surface, including the fissures. They may abut vessels. They're typically lower zone predominant, and this implies a hematogenous route of spread. And we know that miliary infection comes to the lungs through the bloodstream, as well as hematogenous metastases, and of course septic emboli. So here in the illustration, we have solid nodules, cavitary nodules, and some small miliary nodules in a random distribution. Here's a patient with metastases. You can notice that there's a somewhat lower zone predominant, certainly more down here than there are above. A number of these are touching the pleural surfaces. It's hard to recognize the fissures here, but they are there, and they're abnormally nodular in their appearance as well. Disseminated fungal infection, and this patient had HIV, and again, random distribution. Some of these do touch the pleural surfaces. The fissures here are very hard to see, but they're sort of studded also. And don't forget, if you see cavitary nodules, think about septic emboli, but of course some metastases can be cavitary in appearance as well. Just think of steel wool, if you will. I pulled a piece of steel wool apart here to see these irregular reticular opacities that they correlate with here in a patient with early pulmonary fibrosis. And think back to that all that interstitium within the secondary pulmonary lobule, as well as the septa themselves. And this may be a mild, sort of fine looking reticular opacity or much more coarse, where the anatomy that is the topic of this presentation is really totally distorted, and the lungs will slowly lose volume as this fibrosis progresses. Honeycombing can form a cystic appearance here with thick-walled structures, the cystic pattern. So the anatomy here is really obscured because we have honeycombing depicted in multiple tiers of thick-walled cysts. We have single tiers of paraseptal emphysema, and here some indistinct areas of central lobular emphysema, which are not really cystic appearance because the walls are really imperceptible. So you want to keep that in mind. This is, of course, typically an upper zone finding in patients who are smokers. This patient has diffuse thin-walled cysts everywhere throughout both lungs, in a classic case of the rare entity of lymphangiomyomatosis. This patient has central lobular emphysema with indistinct bordered areas of low attenuation. And on the right, we have some honeycombing, multiple tiers, and some single tiers of thicker-walled cysts associated with findings of fibrosis. And these are the findings you'll want to look for. Here the anatomy is very distorted. You can recognize some irregularly thickened interlobular septa. You can see some traction bronchiectasis, which again, you shouldn't see airways out this far in the periphery of the lung. And this is a result of the retractile properties of the underlying fibrosis. And lastly, you'll hear us talk about mosaic attenuation on inspiratory images and air trapping on expiratory images. So again, we're back to considering expiration here. This refers to a sort of patchy, somewhat geographic appearance to the lungs with areas of differing attenuation. Some of these will follow the outlines of the underlying secondary pulmonary lobule. This example, you see some patchy increased ground glass opacity here in some areas of darker lung, and notice that they're sort of patchwork, if you will, but in some areas you can often find areas that are more sharply demarcated, and those reflect, again, the underlying anatomy of the secondary pulmonary lobules. And notice that the differential here is going to involve airways, interstitium, and vascular structures. So anatomy is key to understanding high-res CT.
I'm going to talk about differential diagnosis and patterns. I think there's no other subject in medicine where a multidisciplinary approach to diagnosis is as important as in interstitial lung disease and diffuse lung disease in general. And you are best as a radiologist to sit in a room with your pathologist and with your pulmonologist and discuss these cases face to face, and that's where we are the most accurate. Of course, in this slide, given my bias, radiology is on the top, but you could invert this in any particular direction. So my goals today are to talk about using that multidisciplinary approach to come up with a diagnosis, and how you as a radiologist should listen to your clinician and listen to your pathologist in determining what you think about these cases. I'm going to talk about some of the most important HRCT patterns. It's impossible to talk about all of them in 30 minutes, but I'm going to talk about some of the more important ones. I'm going to talk about how you incorporate pathologic information. In interstitial lung disease, pathology is not necessarily the gold standard, so sometimes the CT may be more specific than pathology, and you need to know when that's the case and know when to defer to your pathologist for diagnosis. And then talk about a couple emerging diagnoses which were addressed in the recent reclassification of the interstitial pneumonias, which came out recently. So, you're sitting in that room with your colleagues and thinking about interstitial lung disease, and I tend to break it up into several categories: idiopathic, connective tissue disease, exposures, and then a group of rare diseases. And in our practice, it tends to be about a third idiopathic, a third connective tissue disease, and a third exposures, with a mix of these miscellaneous diseases, which usually have a characteristic HRCT appearance or have some characteristic clinical presentation. Notice HP, hypersensitivity pneumonitis, is actually in both idiopathic and in exposures, and that's an important thing. When you're listening to the clinicians and there's no exposures, HP is still definitely on the table because approximately 50% of patients with hypersensitivity pneumonitis do not have an identifiable exposure. And it may be, you may be the only one to distinguish HP, in particular, HP from IPF. The radiology is actually quite suggestive of HP in particular cases. So age is an important thing to think about when talking about the clinical information. For instance, idiopathic pulmonary fibrosis virtually always occurs in patients over the age of 50. And is in fact the most common cause of fibrosis in that age group. So if you're talking about someone who's 35 and has fibrosis, that's a very unlikely diagnosis. And then there are other diseases that present in young people, particularly connective tissue disease, sarcoid, and LAM. And then there are other diseases that present in a wide age range. So age is very important. And then when you're listening to that clinical history and they're talking about this and that and exposures and travel and et cetera, really these inhaled and drug exposures are probably the most important thing to listen for, whether these are cigarette smoke, certain dusts, organic antigens, and then, of course, this is the one people always forget about is drugs, things like nitrofurantoin, amiodarone, chemotherapeutic agents. So this is really the key clinical information that you need to get other than age. Now, I talked briefly about physical exam. This is a patient came in which looked really end-stage lung, lots of honeycombing. We said this is probably going to be UIP, but it's hard to be sure. It's just end-stage lung. And the pulmonary fellow looked at me and he said, well, the patient doesn't have Velcro rails in exam. I don't believe that they have a fibrotic lung disease. And of course, as radiologists, I don't have to convince you that the CT is far better than the physical exam in detecting these abnormalities. But I think the physical exam can be very useful in detecting patients with connective tissue disease, whether they have sclerodactyly or telangiectasias or other things which we're not going to see in the CT scan. In fact, clinical history and physical exam make a large part of diagnosis in connective tissue disease. So that's what I think is most important to listen for when they're talking about physical exam, not so much whether the patient has Velcro rails and things like that. So this is a good example of how to use clinical information. This CT scan needs to be interpreted in the context of some very basic clinical pieces of information. And this is, as Dr. Abbott talked about, this is a nice example of central lobular disease. Notice the nodules here are about 1/2 centimeter from the pleura. And that includes both the fissures and the peripheral subpleural interstitium. And when the nodules are in that distribution and of ground glass opacity and diffuse, what are the most likely diagnoses? Well, number one is hypersensitivity, and the majority of patients with subacute HP probably have some kind of identifiable exposure, usually birds and mold. But if they're a smoker, it's going to be a very, very different pattern of injury. Then it's going to be respiratory bronchiolitis. And in fact, hypersensitivity is rare in smokers. It happens, but smoking is somewhat protective against HP. Connective tissue disease, you maybe want to think about follicular bronchiolitis, which can present in patients with scleroderma or Sjogren's or other things like that. Certain pneumoconiosis, mainly siderosis, and then if they have acute symptoms, maybe you consider a viral infection or acute HP. So very basic pieces of clinical information really help to drive what you think about as a radiologist about what the diagnosis is. And in fact, a combination of clinical history and that CT is usually diagnostic of a disease, and you don't need a pathologic confirmation. And so when I think of HRCT patterns, I group them into 1 to 3 categories. The CT is definitive for either one pattern or one disease, such as in this patient with usual interstitial pneumonia. I don't need a pathologist to tell me this is UIP. We all know as radiologists this is almost certainly going to be UIP. Number 2 is, like I just showed you, a combination of this basic clinical information plus the CT together make diagnosis, almost definitively without pathology. And then lastly, there are cases where you just have to throw up your hands and say, here's some patchy ground glass, maybe a little bit of reticulation. Patient, I don't know what the patient has. The CT is totally non-diagnostic. You need pathology and clinical information in this case. Those are what drives diagnosis. And so you should decide which one of these categories each of your cases you see clinically is going to be into. And it's very important for everyone to understand that the relationships of the pathology and the radiology and the diseases the patient has. And this is just more of a reference slide than anything, but when I see a case of usual interstitial pneumonia on CT, I'm essentially predicting a pathology, a pathologic pattern of injury. That is not a disease. And each one of these histologic patterns has a radiographic correlate and has multiple diseases that can lead to that histologic pattern of injury, one of which is idiopathic. And sometimes that's the most common, such as IPF is the most common cause of UIP. And other times there are known diseases that lead to that pattern. And those known diseases are usually indistinguishable radiographically and pathologically from the idiopathic disorders. So that distinction is made clinically. And this is true for any of these pathologic or histologic patterns of injury. So when I see a case like this, very typical honeycombing, traction bronchiectasis, a little bit of reticulation, subpleural basilar predominant. This is almost certainly usual interstitial pneumonia. I'm predicting a pathology, and these are all the pathologic features of UIP. But I'm almost, my specificity for predicting the pathology correct in a case like this is about 95, 97, 98%. And so usually this obviates biopsy in these cases. And in fact, UIP on CT is the most important pathologic, or most important pattern of injury that we can see. And we can be predictive in certain cases. And in this article in 2011, they divided the CT into 3 levels of confidence that it represents UIP. So whenever you see fibrosis on CT, think, which one of these categories am I in? Is it definite UIP, in which case you have subpleural basilar predominant honeycombing, reticulation, and absence of features inconsistent with UIP? Is it possible UIP, which is the same as definite UIP except you lack honeycombing? Or are there features inconsistent with UIP? And I'm going to go into those in much more detail. This is a case of definite UIP. Patient does not need a pathologic confirmation of diagnosis. And clinically, the pulmonologists are going to tease out, is this idiopathic UIP, in which case we're going to call it idiopathic pulmonary fibrosis? Or is this secondary to some other known disease like rheumatoid or drugs or asbestosis? And these can almost always be teased out clinically. Radiographically, they look the same. Histologically, they usually look the same too. Here's a patient who came in with sort of patchy ground glass, maybe a little bit of reticulation. I didn't know what this was. We considered this inconsistent with UIP. And the final pathologic final multidisciplinary diagnosis after path was attained was idiopathic pulmonary fibrosis. So some patients who are considered inconsistent with UIP by CT criteria actually will get a diagnosis of idiopathic pulmonary fibrosis. And in fact, in this article, of the biopsy-proven UIP cases, about 60% were considered low probability for UIP pattern on CT scan. Of course, they probably got their biopsy because the CT was atypical. But in fact, in majority of these path-proven cases, another pattern of injury was favored. So atypical cases of IPF are common. IPF is by far the most common cause of interstitial lung disease over the age of 50. So usually you don't like to bet against IPF since it is relatively common. I think this is particularly true with the familial fibrosis syndromes, which is the rare situation in which you have someone with a UIP pattern under the age of 50. And these tend to present in very atypical patterns. This is all 4 patients from the same family, all with inconsistent with UIP patterns, and all with differing presentations. Some have ground glass, some have cysts, some have reticulation, different distributions. And this is probably a relatively unrecognized cause of lung fibrosis. And in fact, as many as 20% of cases of IPF may be familial or have some close relatives. These patients have close relatives with fibrosis. And they may present in a younger age than the typical IPF patients. The pathology originally was described as UIP, but in Kevin Leslie's groups has actually shown that a majority of cases are unclassifiable, so atypical. And in fact, the radiology tends to be atypical as well. Unusual, more ground glass, unusual distributions. So these are atypical cases on CT scan. Just to mention that as maybe one of those cases that are classified as inconsistent with UIP that actually turn out to have IPF and may present at a younger age. Let's delve into this a little bit more, this inconsistent with UIP categories. This is a very important one because I think particularly for hypersensitivity, many patients don't have an exposure, so the clinicians can't distinguish IPF from HP because neither of those patients are going to have an exposure. And you, as the radiologist, may be the only one to suggest that diagnosis, and it's a very important distinction to make. Here are some of the most common diseases or patterns of injury to mimic idiopathic pulmonary fibrosis. This is a big one. Nonspecific interstitial pneumonia is also a big one. Occasionally smoking-related lung diseases, and then very rarely end-stage sarcoid, which usually presents in younger patients. So the goal of these criteria is to be specific for UIP, but not necessarily sensitive, and the goal is to try to prevent these patients who have hypersensitivity or what other diseases getting labeled as having idiopathic pulmonary fibrosis. So these are the features inconsistent with UIP, right? Ground glass opacity, significant mosaic perfusion air trapping, and that's usually bilateral in 3 or more lobes, nodules, cysts, consolidation, and then atypical distribution, usually meaning more upper lung, more central disease. So let's talk a little bit about each one of these. Ground glass is one of those things that often we use it as a way to distinguish usual and nonspecific interstitial pneumonia. So let's talk about that for a second because those share a lot of features. They're often fibrotic. They're often in the same distribution. They share a lot of findings. And the important distinguishing features between usual and nonspecific interstitial pneumonia is that the most common cause of UIP is the idiopathic disorder associated with that pathologic pattern of injury, which is idiopathic pulmonary fibrosis. Whereas NSIP usually is known diseases with identifiable clinical syndromes. By far the most common is connective tissue disease. Occasionally HP and drugs will be in this category. And this idiopathic NSIP, which I'm not even sure is a real disease, is rarely patients get labeled with that. But the majority of patients will have connective tissue disease. On CT, the ways we attempt to distinguish is, well, honeycombing is typical of usual interstitial pneumonia. Ground glass opacity, traditionally we've used that as being much more suggestive of nonspecific interstitial pneumonia. We'll talk about that in a second. And then this other finding, the sparing of the immediate subpleural interstitium, is very suggestive of nonspecific interstitial pneumonia. So let's talk a little bit about each one of those. Actually, rheumatoid patients are an interesting group because in our experience, they're about 50-50 UIP versus NSIP. And in this recent article, a definite UIP pattern in rheumatoid, when you compare that with the pathologic diagnosis, confirmation, that was highly specific for a UIP pattern in pathology. And this is mirrored in the IPF literature as well. So not necessarily highly sensitive, but highly specific. What about possible UIP? This study from the University of Michigan suggests that if you take all patients over the age of 50 or 55, anyone who has significant fibrosis usually has UIP. In other words, you don't even have to look at the CT scan. This patient has reticulation without honeycombing. I don't care. This would be considered possible UIP, but if they're over the age of 50, they very likely have UIP anyway, so you probably don't even need a biopsy in that case. I would have to say that's not our experience because we see a lot of hypersensitivity and a lot of connective tissue disease. But in that article, an interstitial score of 1, which correlates to about reticulation in every lobe, had 100% specificity for UIP. And so there's some controversy as to what a possible UIP pattern means, but still, these patients will almost always get a biopsy if they can get one. Ground glass opacity, a finding that is inconsistent with UIP. One of those features that we say, okay, well, it's favoring NSIP. It turns out it's not all that good. It may be fairly sensitive, but it's not specific for NSIP at all. I think this has to do with differences in the way we call ground glass. I call it differently than maybe many people do here. So ground glass is not a really useful distinguishing feature. But certainly subpleural sparing is a very, very good way of distinguishing UIP from NSIP. Nice example of myositis lung with this peripheral distribution of reticulation, but notice that sparing of the immediate subpleural interstitium. Highly specific, our numbers that in our practice is much higher than this for nonspecific interstitial pneumonia, usually connective tissue, occasionally HP, occasionally drugs, occasionally idiopathic. This is a little bit confounded by the fact that you can take a patient who has classic nonspecific interstitial pneumonia, and as you follow them over time, a certain percentage of those patients evolve to more of a UIP pattern. So it depends upon where you catch them in that phase of disease. This is, in our experience, one of the most important features that's inconsistent with UIP, and that's significant mosaic perfusion or air trapping involving 3 or more lobes. And that combination of fibrosis with honeycombing and significant mosaic perfusion or air trapping in 3 or more lobes is highly suggestive of hypersensitivity pneumonitis. This actually, a patient got a VATS that showed UIP, was labeled as IPF, and when they got their lung transplant, it was classic hypersensitivity. So in fact, the CT was more suggestive of the diagnosis in this case than the VATS diagnosis. Remember, it must be significant. It can't just be one lobule or one lobe. These are less frequently seen, but certainly are suggestive of other diseases, alternatives to IPF. Small nodules like in hypersensitivity pneumonitis. Cysts, this is a nice example of cysts mimicking honeycombing. Notice the more central disease, which you shouldn't see with honeycombing, the lack of reticulation traction in a patient with lymphoid interstitial pneumonia. And then consolidation, this is a patient with combination of NSIP and organizing pneumonia in the same lung regions who has connective tissue disease. So there's some other features that would be inconsistent with UIP. And then lastly, distribution, which is also perhaps very important, almost as important as mosaic and air trapping. This is a patient who has lots of honeycombing, lots of fibrosis. Notice the distribution is not subpleural predominant. It's very even as you go from central to peripheral. And this patient also had sparing of the immediate costophrenic angles. Another example where if you biopsied here, you may get back a diagnosis of UIP, but on the explant, this was classic hypersensitivity based on distribution. Now let's switch gears for a second. We talked about UIP, which is probably the most important pattern you're going to see in a CT scan. This is another very important pattern, and it combines 2 features which are by themselves relatively nonspecific, but when you put them together, they are highly specific for one disease. And the 2 features are ground glass opacity, changes below the resolution of CT, and in essence, the most nonspecific CT finding there is. It can be alveolar, it can be interstitial, inflammation, infiltration, fibrosis, totally nonspecific. Differential is broad and depends mainly on symptom duration. Acute symptoms, edema, infection, DAD, hemorrhage, chronic symptoms, interstitial pneumonias, malignancies, other things, lymphoproliferative disease, etc. Very nonspecific finding. Mosaic perfusion on the other end, so ground glass, the whiter lung is abnormal. Mosaic perfusion, the dark lung is abnormal. And you can call this, some people call this mosaic attenuation. We tend to call it perfusion because we think it has to do with differences in perfusion. Decreased perfusion to the lung results in lung which is too dark. And that may be because the airways are obstructed, causing hypoxia and reflex vasoconstriction, or it could be due to vascular disease like chronic PE. It's a broad differential. Any airways disease or any vascular disease can do this, but when it's the main or the only finding, it tends to be one of these four. Bronchiolitis obliterans or constrictor bronchiolitis, the most common cause of which is a post-viral childhood viral infection. Asthma, hypersensitivity that may present with isolated mosaic perfusion, and then rarely chronic PE in particular of the vascular disease. But this is the most common one, constrictor bronchiolitis. And how do you distinguish ground glass, white lung abnormal, from mosaic perfusion, dark lung abnormal? Well, mosaic perfusion tends to be very geographic and sharply demarcated. You can draw with a pencil exactly where one ends and one begins. If you see in normal patients as they breathe out, the normal lung should become whiter with the blue arrow. If the lucent lung stays lucent on the expiratories, it suggests that that's the abnormal lung. And not only is it mosaic perfusion, but it's mosaic perfusion from airways disease. And then lastly is vessel size differential. Notice the big vessels in the normal white lung here, and the smaller vessels in the abnormally lucent lung in a patient with chronic PE. So vessel size discrepancy. But it's really most powerful when you put these two together. And you have a combination of ground glass opacity and mosaic perfusion. So you have both white and dark and relatively normal or in-between lung in the same patient. And that's called our favorite sign. We like food signs in radiology, particularly at UCSF. We like this. This is the head cheese sign. And the head cheese sign is a combination of usually three lung densities. Ground glass representing an inflammatory or infiltrative component of disease. Mosaic perfusion representing areas of airway obstruction, reflex vasoconstriction, and relatively normal lung. And it gives this kind of mosaic of different densities, just like the meat you see here, which is better appreciated in Europe. I think Europeans know head cheese better than Americans do. Of course, significant amounts of each density must be present, and the importance of this pattern is that it's virtually always HP, even when you don't have an exposure. It's almost always hypersensitivity pneumonitis. And here's another nice example. Darker lung, whiter lung. This patient actually even has a few ground glass central lobar nodules, but this kind of heterogeneous mosaic of different densities. Looks just like the meat. Thank you to Richard Webb and Oscar Meyer for the slab of head cheese that's superimposed on the CT scan here. There are, of course, there's always a differential, but almost always these can be distinguished by clinical means. So cigarette smokers, there's going to be more this overlap of respiratory bronchitis and DIP, smoking and lung disease. So you can see there's a differential diagnosis, but in our experience, even without an exposure, this is almost always hypersensitivity pneumonitis. And we see a lot of HP. I think there's geographical differences in HP around the country, but you can see that all of these CT patterns are actually very suggestive of HP. These two in particular, a combination of fibrosis and mosaic, or head cheese. This one usually needs some clinical information. The question is, why do you need pathology in these cases, or any case where the CT is almost diagnostic of a particular pattern of injury? Of course, if it's non-specific pattern on CT, you need pathology in most cases because you can't make the diagnosis confidently on the CT scan. In this case, most cases where you have these patterns of injury, like this ground glass central lobar nodules, you have a clinical history. But what if you don't? What if you see this patient and there is no exposure, no cigarette smoking, no connective tissue disease? What do you do then? And so here's an example of head cheese, and I'm going to call this almost always HP, unless there's a clinical reason not to. The patient had a VATS biopsy, came back non-specific interstitial pneumonia. Our pathologist, who's very good, thought it was connective tissue disease. Final multidisciplinary diagnosis is HP, and a couple months after he got the CT scan, he pulled up his mattress, and he found all this nasty mold under his mattress. So it clearly was a case of HP. And so we find pathology can be misleading in these cases, can occasionally suggest rare diagnoses, but a bit controversial about whether you need pathology. What about a case like this? Young 35-year-old guy with perilymphatic nodules. Notice the nodules that are clustered along the subpleural interstitium and in the peribronchovascular interstitium. Notice how there's patchy and there's large areas of normal lung, so it's very classic perilymphatic nodules. Usually that's sarcoid. There are other things that can do that, malignancy, pneumoconiosis, lymphointerstitial pneumonia, amyloid, but most cases you can be able to distinguish these clinically from this one, which is idiopathic in a young person. Do you really need pathology in these cases? And I think the answer is, well, people don't want to make a definitive diagnosis of sarcoid when the malignancy is even a 1 in a million. So then why do we accept a UIP pattern as being definitive for IPF without pathologic confirmation? And I think the answer is, well, it's much less important to distinguish UIP from end-stage HP because their survival is probably the same. This is occasionally patients with hypersensitivity will get into an IPF trial because they have this classic definite UIP pattern. All right, great. So let's finish off in the last few minutes with a couple emerging diagnoses. Here's one, apical fibrosis, there's traction bronchiectasis, there's reticulation, there's architectural distortion. As you get down to the bases, it becomes less severe. There was also quite a bit of pleural thickening in the upper lobes. This is a patient, this is a newly described diagnosis called pleural parenchymal fibrolastosis, which you may or may not have heard of, but was recently described. And as these things start, they start as a pathologic description. The pathologists notice a specific pattern of injury that they find unique, and then we all catch up to try to figure out what these patients present as and what the radiology is. It's usually idiopathic. Mortality is generally pretty bad, at least in these small case series, and the radiology is this: upper lung apical predominant fibrosis with associated visceral pleural thickening. So this is another one that people have been talking about lately. Focal, sort of rounded areas of consolidation with irregular margins, kind of patchy bilateral, lots of ground glass in between. This is a patient with acute fibrinous and organizing pneumonia, which is another sort of emerging diagnosis. Again, this starts with a pathologic description. It's not quite DAD, it lacks the hyaline membranes, but it's kind of close. And people wonder, is this a variant of diffuse alveolar damage? I tend to think personally that's what it is, where you just don't catch the hyaline membranes. It presents usually acutely or subacutely, rapid progression to death or full recovery. So there's quite a spectrum of clinical presentations. And the causes tend to be idiopathic. And the features of this tend to be some overlap of, or at least in radiology, of organized pneumonia and diffuse alveolar damage. You get the sort of focal nodular areas of consolidation. They're typical of organized pneumonia with the more diffuse ground glass, which is more typical of diffuse alveolar damage. I think perhaps the most interesting correlates to these two new emerging diagnoses are thoughts on lung trends. This is just a little tangent, but usually chronic rejection in lung transplant we always have thought has been bronchial obliterans with mosaic perfusion, but we're actually finding that chronic rejection has multiple phenotypes, one of which is pleural parenchymal fibrolastosis, which we call restrictive allograft syndrome, and another of which is acute fibrinous and organized pneumonia. So there's clearly some overlap, some patterns of injury which overlap between our patients who are lung transplant recipients and those who are not.
Diffuse lung diseases are a complicated set of disorders. And I'll let you into the secret. We as chest radiologists also find them quite difficult. But we do find them intriguing, so we keep on investigating these further. Now, there is no doubt, as I think you've gathered, probably from your own practices and also from what you've heard in the previous two excellent lectures, that HRCT really is sitting there in the center of the diagnostic process. But that diagnostic process is really not straightforward. Now let's put that into some kind of context. Why is it so difficult? Well, if you actually read the literature, you'll find that there are well over 200 recognized diffuse interstitial lung diseases. Now the problem is that the lung really doesn't have that many pathological responses. It has mosaicism, it causes consolidation, you may get bronchiolitis obliterans, there are a variety of patterns, but actually the lung's response to injury, whatever that injury may be, is relatively stereotypical. The problem further then is that those pathological patterns really in day-to-day practice manifest as only 5 to 6 HRCT patterns. I mean, I'm sure there are more, of course there are more, but when it comes to common patterns, we are really dealing with 5 or 6, and you've heard many of those in the two previous lectures. But that, again, is not quite the biggest problem, because the biggest problem is the clinician who comes along and says, I want one diagnosis, and that's when we run into problems. So that's why diffuse lung diseases are so difficult. What are they? Well, here's a little bit of revision. The diffuse interstitial lung disease, the term is actually a umbrella term which captures a variety of entities. So there are those which are of known cause, and you've heard of some of them, the drugs, connective tissue diseases. There are the granulomatous diffuse interstitial lung diseases, and sarcoidosis par excellence is the key example of that. And we have a ragbag of others, the interesting ones like Langerhans cell histiocytosis, lymphangioliomyomatosis, and then we've got the interesting group of the so-called idiopathic interstitial pneumonia. So that kind of puts it into some kind of context. Now, what I'm going to do in this next 26 or so minutes is to cover some of the basic ground rules, because I think even as chest radiologists, we have a system when we look at HRCT. Now, we may do that at a subconscious level, but it is a kind of useful survival guide, which I hope I can impart to you by the end of this lecture. And we'll do that by reviewing some illustrative cases. First and foremost, the most important rule, avoid overcalling. What do I mean? Well, sometimes the HRCT is absolutely normal. And we're not saying the lungs are normal. All we're saying is that the HRCT examination is normal. And that's a crucial point to understand for us as radiologists and also for the clinicians that we report to. Because what we're saying is the HRCT is not picking anything up. And I'm not going to be able to pick anything up regardless of whatever history you give me. Now, what might make you think that the CT scan is abnormal, when in fact all you're looking at is a variation of normal or a variation of physiology. Now you look at that CT scan, and I'll get many of my registrars or juniors come to me saying, is that really ground glass? And actually that question is wrong. It is ground glass. The density of that lung has increased. And remember, key principle of CT is that CT is essentially one exquisite density meter. It is very sensitive to changes in the amount of air inside the lungs. So that is real ground glass, but it's physiological ground glass because the patient hasn't taken a great breath in. And what you need to do is to look at the scan and say, am I looking at that posterior tracheal membrane and is it bowing backwards? Because that tells you the patient has taken a good breath in and that you're not looking at an expiratory scan. For similar reasons, we've all seen scans that look like this, and again, it's all related to the amount of air inside the lungs. The amount of air in the lungs determines the density of the lungs. And that is why, in pediatric cases, we see increased density. Is that real ground glass? Of course it's real ground glass. There's an increase in the density. Why? Because there are fewer alveoli. Fewer alveoli mean less air. Less air means the lungs look white. So this is not a question of disease. This is real ground glass specification, but it's physiological, and we can understand why that is. And we've all seen scans like this. Now, this shouldn't be too much of a problem because nowadays with multi-slice CT scanning, we can look at coronal images, and what you're looking at the bases of the lungs on the axial image is a manifestation of less air inside the lungs. Less air equals increased density, so that is ground glass specification, but it's caused by atelectasis. So the question you should be asking is not, is this really ground glass? The question you should be asking is this disease? That's the most important question when it comes to HRCT interpretation. Now, many of us look at CT scans, which are of very thin sections, and we are now generating images of 0.5, 1 millimeter section collimation, and that has a tendency to make lungs look quite nodular. And the reason for that is because the smaller the section, the greater the likelihood that vessels will pass in and out of that plane of that section. And you can imagine how that nodule and all these vessels will manifest on the CT scan if you simply look at one section as dots, so it will look nodular. Now, nowadays, that shouldn't be so much of a problem because we can generate MIP images and we can tell vessels for what they are and we can tell nodules for what they are. So remember, be careful when you're looking at a CT scan not to overcall nodules, particularly when you're looking at very thin sections. So that's the first rule, don't overcall. Second rule, this is also very important. Now, we've heard about the importance of history. There are times when the history will push you to saying things you don't really believe and you don't really want to say. Here's a classical example. Here is a CT scan. You're looking at this in your reporting section. And this is the request form, and it comes from a very eminent professor of respiratory medicine, and he suspects diffuse interstitial lung disease. And lo and behold, what you try and do is you go, well, he's a very clever man. I better not upset him. I'm going to start picking up little abnormalities. And what you will do is then generate reports such as this. This is a completely normal CT scan. And I suggest to you, if you hadn't looked at the history, you may not have focused on those little areas of apparent reticulation in the lower zones of the lungs. What I suggest is you look at the CT scan first, then look at the clinical picture, and then put the two together, rather than the other way around. Try it the next time that you report an HRCT examination. Rule number 3, there is a certain amount of observer variation. I am not going to say the same things as my colleagues, and I may not say the same things on different occasions. And there is a certain amount of observer variation. This is a fact of normal clinical medicine, and it is certainly a fact of normal radiological practice, and one should accept this. Now, we've all generated reports something like this. The appearances are those of an interstitial lung disease, and they're consistent with, well, you can fill in the gaps for yourself. I think this looks like sarcoid. I think this looks like hypersensitivity. But the fact remains that many times, and again, I'll let you into a secret, us chest radiologists think like that. What you really want to say is this: I haven't got a clue. And that is an important clinical fact. If you don't know what this is, it may be, if you're an experienced chest radiologist, you're looking at an atypical manifestation of the disease. But there are reasons why a radiologist may simply have to say, I have not got a clue. And here they are listed. It may be that your experience is not sufficient. You haven't seen enough cases of diffuse interstitial lung disease. It may be that you're looking at a common disease, but it's presenting in a very atypical fashion. And Brett talked about the atypical manifestations of a UIP pattern. And it may be that you're looking at something which is very, very non-specific. It is not possible to make a confident radiological diagnosis in the absence of the full clinical picture. Now, let's just see a few examples. Chronic extrinsic allergic alveolitis, you get mosaicism, you get ground glass opacification, you get signs of fibrosis. But unless you knew that in a small proportion of patients, you also can get cysts inside at the lungs in people with chronic hypersensitivity pneumonitis, you may not know that this is a case of chronic hypersensitivity pneumonitis. With experience, that will come. Some diseases are there to trick you. Sarcoidosis is the classical example. Now, we all know, or we think we know, what sarcoidosis looks like, but it is the great chameleon diagnosis in the lungs. And in some patients with sarcoidosis, you will have an appearance that looks exactly, or almost exactly, like UIP. And now, with the best will in the world, you will not be expected to make a diagnosis of sarcoidosis in a picture that looks like that. And that is a proven case of sarcoidosis. And then there are scans such as this, which, in the absence of any history, are wholly non-specific, widespread ground glass opacification. So unless you knew that this patient was acutely breathless, was hypoxic, and the hypoxia was difficult to treat, you wouldn't be able to make a diagnosis of ARDS. That could represent blood, that could represent simple pulmonary edema. So the clinical, so the radiological features may be difficult to interpret, and there's a certain amount of observer variation that we have to accept, and more importantly, our clinical colleagues also have to accept. Rule number 4. It is important to understand the HRCT patterns, and more importantly, the links between those CT patterns and what it means at a pathological level. Now, what do I mean? Well, but those CT patterns are caused by certain pathological processes. Remember, at the beginning of my lecture, I said the range of pathological processes is relatively small. The radiological patterns is even smaller. So we need to understand the links between those. And I also said that common patterns are common. So what are the common patterns that you will see on CT when you're interpreting CT scans? So one of these patterns is consolidation. What does consolidation mean? Well, consolidation indicates a pattern of airspace disease. That is a fundamental fact that we have to link the radiological pattern with what it means in terms of where the pathology is. When you make that link, you can then say, okay, I know the pathological processes that can occupy the airspaces. So then, if the history is of a patient who may be young, who has a cough which is productive of sputum, you can suggest that this pattern is caused by infection. By contrast, if the history is that of an 80-year-old man who's been treated with repeated courses of antibiotics and is not responding to treatment, well, in that patient, that same radiological pattern may indicate a tumor. You get my drift. What about reticular pattern? Well, reticular pattern, 9 times out of 10, you'll be looking at an interstitial lung disease. And when you know that, when you make that link, you can say, well, these are the possible causes of an interstitial lung disease. And then you go to Brett's lecture and you say, well, what are the patterns, what are the distribution? And you attach a label to what you're seeing on the CT scan. Now, ground glass opacification, as you've already heard, is a non-specific radiological sign. At a very basic level, all it means is you've displaced air partially from that region of lung. And that is an absolutely crucial thing to understand. Anything which partially displaces air from the lung will cause an increase in density. That's why a ground glass opacification can be due to a pure interstitial lung disease, as in this patient with pulmonary hemorrhage, and it can be due to a mixture of processes. The simplest example is pulmonary edema. You get exudation into the interstitium and then into the air spaces, and all of that displaces air partially from the lungs, and that causes increased density, which manifests as ground glass opacification. Now, ground glass opacification, the first thing I do when I see ground glass is I look at the airways, because that tells me that whatever else is going on in the lungs, there is a component of lung fibrosis. And it may be very obvious, as in this case here, or indeed it may be extremely subtle, as in this case here. But when you see ground glass opacification, the next thing to look at is the airways inside the areas of ground glass. If they're dilated, it tells you you've got a fibrosing lung disease. Now, you may not know what the actual etiology is, but even that information to impart to a clinician to say there is fibrosis in the lungs is crucial clinical information. Rule number 4, common things are common, and it's worth knowing the common patterns of lung diseases. This is by no means a comprehensive list of diffuse interstitial lung disease, but it's arranged in some rough order in terms of the ease of diagnosis. Now, the diagnosis of IPF, or the UIP pattern, which is the diagnosis that we make, and that's perhaps something that we can make with a reasonable degree of confidence, assuming that it's a typical pattern. That's not always the case. But as we go further down that list, it becomes more and more difficult because the appearances become more and more non-specific. Now, I know this is about HRCT, but the important point to make, that distribution of disease is extremely important when it comes to chest X-ray diagnoses, because there are certain diseases that live in the upper zones, there are certain diseases that live in the lower zones, and there are certain diseases that are very random. Now, for ease, I've divided the lungs up into 3 zones: upper, mid, and lower zones. And the question is, what is the predominant distribution of disease in this chest X-ray? And just to kind of help you, here is the X-ray again. So this is a predominant mid and upper zone disease. This is the CT scan. Now, the advantage of CT is, in addition to the craniocaudal distribution, we can also see the axial distribution. We heard about peripheral diseases, we heard about central diseases. Well, this is a disease process that actually likes the upper zones, as we've already seen. This is the same patient, and you can see that this is a mid and upper zone disease process. The lower zones are not spared, but it is certainly something that likes the upper zones. Also on CT, you can see the relationship to the bronchovascular bundles, and this is clearly a disease process that likes the bronchovascular bundles. Why? Because that's where the lymphatics are, and this is sarcoidosis. And sarcoidosis par excellence is the sort of lymphocentric disease. This is a cut section of the lung, and you can see that the CT manifestations are exactly as you see on that cut section. That bronchocentricity of nodularity is a key feature which allows the chest radiologist to make a diagnosis of sarcoidosis. Now, moving on, this is now related to the second question. Now, this is a disease process. This is clearly in the mid and lower zones, but we're now going to move into CT, and you will see here 5 axial sections on a CT scan. Which is the dominant pattern or patterns? Because we can talk about distribution, but at the end of the day, we have to decide what the dominant patterns are. Is it a reticular pattern with honeycombing? Are we looking at ground glass opacification? Is this a mosaic attenuation pattern? Or are we looking at smoothly thickened interlobular septa? So this is clearly a reticular pattern with honeycombing as the dominant abnormality. And this, of course, is our friend usual interstitial pneumonia. And as you know, we've recently tightened up the diagnosis of a UIP pattern, and based on this paper from Ragu and colleagues, for a radiologist to make the diagnosis of a UIP pattern, it has to be subpleural, it has to be basal, there has to be reticulation with honeycombing. There may or may not be traction bronchiectasis, and those features listed on the right-hand side need to be absent, and those features have been covered. Rule number 5, there are certain pathognomonic features. These are the so-called slam dunks of chest radiology. Now let's just look at a few of those. So what about this? You might look at this and think, Christ, I have no idea what's going on here. But by the end of these next few slides, you will know exactly what this pattern is. What can we see? Well, we can certainly see it's a diffuse abnormality. We can see that there are areas of consolidation. You can see airways going into those areas of consolidation. But they do seem to be highlighting these pulmonary lobules. So this is what is known as a perilobular pattern of consolidation. And if you are following the literature, you will have seen this paper published a few years ago from my old boss, David Hansel's group, of a perilobular pattern. And this pattern is consistent with organizing pneumonia. So the next time you see this pattern with this striking perilobular distribution, think about organizing pneumonia, and you're almost certainly guaranteed to be right. This is the final case. So here we have a CT scan. Clearly, it's very abnormal. Now, I'm going to show you this question. I'm going to show you the images again. It's asking again about the dominant abnormality. What is the dominant abnormality on this CT? Are we looking at emphysema? Are we looking at bronchiectasis? Or are we looking at multiple thin wall cysts? Or, indeed, are we looking at a pattern of honeycombing? So here is the CT scan again. So this is clearly a pattern of multiple thin-walled cysts. They are areas of low attenuation with a well-defined wall around them, so that differentiates it from emphysema. But there are some other features. If you look at these cysts, they do have very bizarre shapes. For example, if you look at this doesn't quite look like a cyst. This looks like a slightly twisted, serpiginous area of decreased attenuation. If you were very eagle-eyed, you would have seen on one of the sections that in amongst those cysts there are some nodules. And again, distribution. On CT scan, paying attention to the distribution is exceedingly important. And here you can see that the tip of the middle lobe and the tip of the lingula are both spared, and indeed that is the same for the lower zones. If you compare with the upper zones, you can see that there is relative sparing of the bases of the lungs. So to summarize, what have we got? We've got cysts with bizarre shapes, we have nodules, at least one nodule was seen on those sections, and then there is sparing, relatively characteristic sparing of the tip of the middle lobe and the lingula, and sparing of the lower zones. And these four features together are highly characteristic of a diagnosis, which is listed here. But these are the causes of multiple cysts in the lungs, and this case is a patient with Langerhans cell histiocytosis. So that is the last of the cases. First and foremost, don't overcall. If a CT scan is normal, it is normal. You're not saying the lungs are normal, you're saying that the scan is not normal, and that is a crucial distinction to make. There is a certain amount of observer variability. Don't kick yourself too much if you're saying something different from your colleagues. This is perfectly acceptable. It's worth knowing the common HRCT patterns: consolidation, reticulation, ground glass opacification, mosaicism. But more importantly, knowing those patterns and knowing what the histological correlates of those patterns are, because then you're halfway down the list of making an accurate diagnosis. I suggest you look at the clinical details after reviewing the imaging. You don't want to be pushed into labeling a patient with a particular diagnosis simply because the clinical information suggests, or your clinical colleague pushes you to making a diagnosis. You should know some of the slam dunks, the common HRCT features of common diffuse interstitial lung diseases.